Myasthenia gravis. Introduction. Myasthenia gravis, MG, is a chronic autoimmune neuromuscular disorder that leads to weakness in the voluntary muscles. It occurs due to the disruption of communication between nerves and muscles, resulting in muscle fatigue and weakness. The condition is characterized by fluctuating weakness that worsens with activity and improves with rest. Though it can affect people of all ages, MG is most commonly diagnosed in women under 40 and men over 60. Definitions. According to the National Institute of Neurological Disorders and Stroke, NINDS, myasthenia gravis is a chronic autoimmune disorder in which antibodies destroy the communication between nerves and muscle, resulting in weakness of skeletal muscles. According to the World Health Organization, WHO, a neuromuscular disorder characterized by varying degrees of weakness in voluntary muscles due to impaired transmission of nerve impulses. Risk factors. Myasthenia gravis, MG, can affect individuals of all ages, but certain groups are at a higher risk due to genetic, environmental, and autoimmune factors. 1. Age and gender-related risk factors. Women under 40 years and men over 60 years are more likely to develop MG. The condition can also occur in newborns if the mother has MG, neonatal myasthenia. 2. Genetic and autoimmune predisposition. Individuals with a family history of autoimmune disorders, example lupus, rheumatoid arthritis, thyroid disease, have a higher likelihood of developing MG. People with genetic mutations affecting neuromuscular transmission, congenital myasthenic syndromes, are at risk. 3. Thymus abnormalities. Thymoma, tumors in the thymus gland, or thymic hyperplasia increases the risk of MG. The thymus plays a crucial role in immune system regulation, and its dysfunction can trigger autoimmune responses. 4. Environmental and external triggers. Infections, viral or bacterial, can trigger an autoimmune response leading to MG symptoms. Certain medications like beta blockers, aminoglycosides, and some anesthetics may provoke or worsen MG symptoms. Pregnancy and hormonal changes may influence MG onset or exacerbation. Etiology. Myasthenia gravis is primarily caused by an autoimmune attack on the neuromuscular junction, but other factors may also contribute to its development. 1. Autoimmune dysfunction. The body's immune system produces autoantibodies against acetylcholine receptors, AChR, blocking nerve signal transmission to the muscles. In some cases, antibodies target muscle-specific kinase, MuSK, leading to muscle weakness. 2. Thymus gland abnormalities. Many MG patients have thymoma, tumors in the thymus, or thymic hyperplasia, enlarged thymus, which triggers abnormal immune responses. 3. Genetic and hereditary factors. Congenital myasthenic syndromes, CMS, occur due to genetic mutations affecting neuromuscular transmission. A family history of autoimmune disorders may increase the risk. 4. Triggers and environmental factors. Infections, viral or bacterial, can worsen symptoms or trigger MG in predisposed individuals. Certain medications, including beta blockers, aminoglycosides, and some anesthetics, can aggravate muscle weakness. Stress, fatigue, and hormonal changes, such as pregnancy, may lead to symptom exacerbation. Classification of myasthenia gravis. Generalized myasthenia gravis, GMG. Affects multiple muscle groups, including ocular, bulbar, limb, and respiratory muscles. Symptoms include generalized muscle weakness, difficulty swallowing, and breathing issues. Ocular myasthenia gravis, OMG. Primarily affects the eye muscles, leading to ptosis, drooping eyelids, and diplopia, double vision. Does not progress to generalized MG in some cases. Neonatal myasthenia gravis. A temporary condition seen in newborns born to mothers with MG. Symptoms include weak cry, difficulty feeding, and respiratory distress, but usually resolves within weeks. Congenital myasthenic syndromes, CMS. Caused by genetic mutations affecting neuromuscular transmission. Unlike autoimmune MG, CMS is not antibody-mediated and usually manifests in infancy or childhood. Seronegative myasthenia gravis, SNMG. Patients do not have detectable antibodies against acetylcholine receptors, AChR, or muscle-specific kinase, MuSK. Diagnosed through electrophysiological studies and clinical assessment. Myasthenic crisis. A severe and life-threatening complication where respiratory muscles become too weak to support breathing. Requires immediate medical intervention, often involving mechanical ventilation. Pathophysiology. Antibody production against acetylcholine receptors. Autoimmune response targets ACH receptors at the neuromuscular junction. Down arrow. Blockage of neuromuscular transmission. Reduction of ACH receptor function leads to impaired muscle contraction. Down arrow. Muscle weakness and fatigue. Progressive decline in muscle strength with exertion. Down arrow. Worsening symptoms with repetitive use. Muscle weakness intensifies with continued activity and improves with rest. Down arrow. Potential respiratory compromise in severe cases. Myasthenic crisis leading to respiratory failure. Clinical manifestations. Muscle weakness that worsens with activity and improves with rest. Ptosis, drooping eyelids. Diplopia, double vision. Difficulty in chewing, swallowing, or speaking. Weakness in the arms, legs, neck, and respiratory muscles. Shortness of breath in severe cases, myasthenic crisis. Diagnostic evaluation. History taking. Onset and pattern of muscle weakness. Patients often report fluctuating muscle weakness, which worsens with activity and improves with rest. Initial symptoms may include drooping eyelids, ptosis, or difficulty swallowing. Weakness typically progresses from the eyes and face to the limbs and respiratory muscles. History of autoimmune disorders. Since myasthenia gravis is an autoimmune condition, a history of other autoimmune diseases, example rheumatoid arthritis, lupus, thyroid disorders, may increase suspicion. Medication and family history. Certain medications, such as beta blockers and aminoglycosides, can exacerbate symptoms. Family history of neuromuscular disorders or autoimmune diseases may suggest a genetic predisposition. Physical examination. Observation of ptosis and fatigable muscle weakness. Eyelid drooping, ptosis, may be noted, especially after prolonged eye use. Muscle weakness increases with repetitive movements and improves after rest. Neurological examination to assess reflexes and muscle strength. Muscle strength is tested in different areas, including the eyes, neck, arms, and legs. Reflexes typically remain normal, differentiating MG from other neuromuscular disorders. Fatigue testing, such as sustained upward gaze or repetitive limb movements, may reveal muscle weakness. Laboratory and imaging tests. 1. Edrophonium test. Purpose: confirms myasthenia gravis by temporarily improving muscle strength. Procedure: a small dose of edrophonium, a short-acting cholinesterase inhibitor, is injected intravenously. Mechanism: inhibits the breakdown of acetylcholine, increasing its availability at neuromuscular junctions and momentarily enhancing muscle function. Positive result: a sudden but temporary improvement in muscle strength suggests myasthenia gravis. 2. Anti-AChR antibody test. Purpose: detects the presence of autoantibodies against acetylcholine receptors. Mechanism: measures levels of anti-acetylcholine receptor, AChR, antibodies, which block or destroy receptors needed for muscle contraction. Positive result: elevated antibody levels confirm an autoimmune cause of myasthenia gravis. 3. Electromyography, EMG. Purpose: evaluates muscle response to nerve stimulation. Procedure: Electrodes are placed on muscles to measure electrical activity as nerves stimulate contractions. Positive result: decreased electrical response upon repeated stimulation indicates impaired neuromuscular transmission. 4 CT/MRI of thymus. Purpose: detects thymic abnormalities like thymoma, tumor, or thymic hyperplasia, which are often associated with myasthenia gravis. Procedure: a CT scan or MRI provides detailed imaging of the thymus gland. Positive result: an enlarged or abnormal thymus suggests a need for further evaluation and possible thymectomy. Medical management. Pharmacological management. Acetylcholinesterase inhibitors. Pyridostigmine helps improve neuromuscular transmission by increasing acetylcholine availability, thereby enhancing muscle contraction. Immunosuppressants, corticosteroids, prednisone, and azathioprine help suppress the immune response to reduce antibody production, preventing further damage to acetylcholine receptors. Plasmapheresis or intravenous immunoglobulin, IVIG, used in severe cases to rapidly remove harmful antibodies or modulate the immune system response during exacerbations. Non-pharmacological management. Physical therapy. Encourages muscle strengthening and endurance without overexertion. Focuses on low-impact exercises to maintain mobility and prevent muscle atrophy. Occupational therapy. Helps patients adapt daily activities to reduce fatigue and conserve energy. Recommends assistive devices like grab bars, walkers, and modified utensils. Speech and swallowing therapy. Provides strategies to improve swallowing and prevent aspiration. Suggests dietary modifications for easier chewing and swallowing. Respiratory support. Breathing exercises to strengthen respiratory muscles. Non-invasive ventilation in cases of respiratory muscle weakness. Lifestyle modifications. Adequate rest periods between activities to prevent fatigue. Stress management techniques like meditation and relaxation exercises. Avoidance of extreme temperatures, which can worsen symptoms. Dietary adjustments. Soft, nutrient-rich foods to aid in chewing and swallowing. Frequent small meals to maintain energy levels. Patient and family education. Awareness about symptom management and early recognition of exacerbations. Training caregivers on emergency response for myasthenic crisis. Surgical management. Thymectomy, surgical removal of the thymus gland in patients with thymoma. Dietary management. High protein, soft diet for those with difficulty chewing/swallowing. Small, frequent meals to prevent fatigue. Adequate hydration to avoid muscle cramps. Nursing management. 1. Impaired physical mobility related to muscle weakness. Encourage frequent rest periods to prevent fatigue. Assist with mobility aids as needed. Educate on energy conservation techniques. 2. Risk for aspiration related to difficulty swallowing. Position the patient upright while eating. Provide soft, easily chewable foods. Monitor for signs of choking and aspiration. 3. Ineffective airway clearance related to respiratory muscle weakness. Monitor respiratory rate and oxygen saturation. Educate on deep breathing exercises and airway clearance techniques. Be prepared to initiate mechanical ventilation in case of myasthenic crisis. 4. Risk for visual impairment related to ptosis and diplopia. Provide an eye patch for double vision. Encourage the use of lubricating eye drops. Prevention. Avoid triggers such as infections, stress, and certain medications. Adhere to prescribed medications to prevent symptom exacerbation. Engage in regular follow-ups for disease monitoring. Maintain a balanced diet and proper hydration. Complications. Myasthenic crisis, life-threatening respiratory failure. Severe difficulty swallowing, leading to malnutrition. Increased risk of respiratory infections. Permanent muscle weakness in severe cases. Conclusion. Myasthenia gravis is a chronic autoimmune disorder that significantly affects muscle function and quality of life. Early diagnosis, appropriate medical management, and supportive care are crucial in improving patient outcomes. A multidisciplinary approach involving neurologists, physiotherapists, and nurses ensures better symptom control and a higher quality of life for affected individuals.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.